Good afternoon and welcome to the Childhood Trauma Learning Collaborative and Early Psychosis Learning Collaborative listening session, Early Intervention for Psychosis in Young People, a Lived Experience and School Perspective, with Kelsey Johnson, Program Manager for the Massachusetts Psychosis Network for Early Treatment, or MAPNet, Raquel Meshlam-Gately, Assistant Professor in the Department of Psychiatry at Harvard Medical School, Dan Johnston, Certified Peer Support Specialist and Let's Lead New England Fellow, Courtney Spitzer, Clinical Research Study Coordinator at Beth Israel Deaconess Medical Center. Kelsey, Raquel, and Dan will give a brief presentation about today's topic, followed by a discussion with the School Mental Health Initiative Director, Dr. Martha Staley, and Courtney Spitzer. We will then open the floor for questions from the audience. I'd like to acknowledge the traditional ancestral unceded territory of the Pawtucket Nation, now known as Arlington, Massachusetts, where Dan is joining us from, the Pawtucket and Massachusetts Nations, now known as Boston, Massachusetts, where Kelsey, Raquel, and Courtney are joining from today, and the territory of the Wappinger Nation, now known as the Greater New Haven, Connecticut area, where Martha and I are joining today. My name is Dana Asby, and I will be your webinar manager and host. Our funding comes from the Substance Abuse and Mental Health Services Administration. The views and opinions expressed in today's listening session are those of the presenters and moderators, not SAMHSA. The Mental Health Technology Transfer Center Network uses person-centered, affirming, respectful, and recovery-oriented language in all activities. During this listening session, please ensure that whenever you are contributing to our discussion via the chat or during the question and answer section of our listening session, that you also use language that is strengths-based, healing, and trauma responsive. Microphones will be muted during the presentation. At designated times, for example, during our question and answer session, you can use the raise your hand feature to request an open mic. When speaking, please be sure to eliminate any background noise. You can also submit questions for the presenters throughout the presentation using the chat. We're pleased to offer the option of closed captioning for this webinar. You can select this option and change transcription settings by clicking the CC Live Transcription button at the bottom of your Zoom screen. Registration affirms your consent to receive an evaluation follow-up link via email and your consent to recording. If you experience any technical issues, please send a private chat to Ingrid Paget, our technical support manager for today's webinar. We're pleased that you joined our listening session, and I'd now like to introduce our presenters and facilitators. Dr. Raquel Meshlam-Gately is an assistant professor of psychology in the Department of Psychiatry at Harvard Medical School. She is also a licensed clinical psychologist and neuropsychologist who is the Harvard Site co-director for the New England MHTTC and the associate director for MAPNet. She directs the Consumer Advisory Board and Neuropsychology Research in the Psychosis Research Program at the Massachusetts Mental Health Center Public Psychiatry Division of Beth Israel Deaconess Medical Center. She has felt privileged to be partnering with the Consumer Advisory Board in participatory mental health research, including recent projects on therapeutic alliance and the quality of life in serious mental illness, as well as renaming schizophrenia. Kelsey Johnson is the program manager for MAPNet. She received a master's degree in public health from Boston University and is dedicated to taking a public health approach to support those who experience psychosis. With MAPNet, Kelsey organizes trainings and works with clinicians to support the implementation of high-quality, recovery-oriented care for psychosis. She also works on projects to increase awareness and understanding of psychosis in primary care settings. Dan Johnston has shared his experiences publicly alongside peers, clinicians, and researchers in the Boston area to advocate for early intervention in treating psychosis. He is a graduate of the University of Massachusetts Lowell in creative writing, and now as a certified peer specialist and part of Let's Lead New England, he seeks to spread stories that inspire hope and galvanize resilience for all those experiencing mental illness. Along with peer support, writing, and speaking, he has been known to cook, to play music, to seek out rocks to climb, trails to hike, and when available, snow to make into forts. Courtney Spitzer is a clinical research coordinator and project coordinator at the Beth Israel Deaconess Medical Center. She has spent the last 3 years researching various psychotic disorders. And Dr. Martha Staley is a faculty member at the Program for Recovery and Community Health in the Yale School of Medicine, Department of Psychiatry, and the director of School Mental Health Initiative for the New England MHTTC. She's trained as a secondary English teacher and has a PhD in public health. She has very extensive experience in population health and epidemiology, qualitative and mixed methods research, design, analysis, and evaluation, and community and clinical intervention implementation. We are so pleased to have this amazing group of presenters and facilitators here with us today. And now I'd love to turn it over to Dr. Raquel Meshullam-Gately.
Thanks so much for the introduction, Dana, and welcome everyone. I am very pleased to be here this afternoon with my colleagues from the New England Mental Health Technology Transfer Center, from MACNet, as well as the Consumer Advisory Board, which is a mental health research group representing a partnership between researchers, clinicians, and/or those with lived experience of mental illness. So in the next 50 minutes or so, we're going to review what psychosis is and early intervention, provide a lived experience and school perspective, and then have an interactive discussion with questions and any comments or experiences that anyone would like to share. Thanks, Kelsey. Before delving into details, I want to start with the points that we hope you'll take home from this listening session about psychosis. The first being, psychosis is a set of symptoms, not a diagnosis. Second, psychosis is more common than people tend to think. Early intervention can help to promote recovery and reduce disability. And you can learn how to talk with young people experiencing psychosis. Next slide. So returning to the first point about psychosis not equaling a diagnosis. Psychosis is a set of symptoms referring to a loss of contact with reality or difficulty telling what's real from what's not. The symptoms can also make it harder for a person to think clearly, to communicate, to relate to others, and to feel emotions. A person may experience psychosis for a variety of reasons, such as in the context of drug use, medical issues like seizures or sleep deprivation, postpartum, traumatic stress, grief, medical treatments, dementia, or psychiatric disorders such as schizophrenia, bipolar disorder, or depression. So when someone seeks help for psychotic symptoms, so many factors are considered, such as the specific symptoms, when they started, the severity, extent of distress and impact, potential causes and influences, so things like whether it might be biological, could drug use be contributing? Might there be a family history of schizophrenia, exposure to any unusual toxins, other kinds of medical causes? We also might think about psychological factors, the person's coping skills and style, insight, attitudes towards adversity. Social and cultural factors are extremely important to consider too, when we try to figure out what the root is of the psychosis. So things like social supports, was there a recent breakup, social media, cultural and generational beliefs about friendship, mental illness. We also consider spiritual factors, what kinds of religious beliefs the person has. And then we also really look at the time course of the person's illness. So there's typically 4 symptom clusters that we see in psychosis. There's positive and negative symptoms, cognitive and affective or mood-related types of symptoms. The positive and negative symptoms are the most well-known and distinctive aspects of psychosis. The positive symptoms are labeled as such because they're added experiences. So things like delusions, hallucinations, and disorganization. Delusions are fixed false beliefs that seem real. So things like feeling that a friend or a neighbor is spying on you, wants to harm you, or people that you care about, that others might be controlling your thinking. Hallucinations are things that people might hear, see, smell, taste, or feel that no one else is experiencing. Voices are typically the most common types of hallucinations. And then disorganization can often be manifest in thought, speech, and behavior. Thoughts can be fast or slow. They may stop suddenly. It may feel as though thoughts can be controlled. It can be hard to concentrate. There may be disorganized speech, like shifting rapidly from one topic to another. And then negative symptoms are labeled as such because they represent a reduction in experiences. So things like with expressed emotion, a person might have trouble showing their emotions. With social interactions, the person might not be talking a lot, might be withdrawing from others. And in terms of functioning, there may be low motivation, declines in self-care, and just overall daily functioning. Sometimes some of the earliest signs of risk we see are with those kinds of negative symptoms. So we may see things like a drop in grades, work performance, having strange kinds of feelings or no feelings at all, trouble concentrating, withdrawing from peers, and things along those lines. People might also talk about, feeling like their mind is playing tricks on them, feeling suspicious, having unusually intense feelings and ideas, and things like that. Next slide. Symptoms typically fall on a continuum based on severity, frequency, and impact. So much like depression and anxiety, and any other kind of condition for that matter. And we all fall somewhere on that spectrum, and that can fluctuate over time or in different circumstances. We really try to avoid using terms normal versus abnormal, but rather familiar versus distressing. So this image provides an example of that continuum. Above the bar are thoughts, and below are different types of perceptions. And you'll notice on this slide, if you look all the way to the right of the bar, another feature apart from kind of the severity and frequency and impact, and that is the person's level of conviction in their kinds of beliefs or the perceptions that they're having. So, what you see here is that my landlord poisoned the air and I'm sure he wants to kill me. So that overall increase in conviction is something you might see on that end of the continuum. Another point I'd like to add related to this continuum of symptoms and avoiding the use of particular terms when we communicate with people experiencing psychosis is that it's very important to use recovery-oriented language, that symptoms can be treated and recovery is possible. So while recovery doesn't necessarily mean a cure, it does mean that individuals can actively move towards improving health and wellness, live a self-directed life, and strive to reach their full potential. Too often, we see that individuals with psychosis unfortunately encounter stigma and discrimination, misconceptions, as well as a host of negative outcomes like feelings of hopelessness and reluctance to seek care. In fact, there have been so many negative connotations associated with the word schizophrenia, including that recovery is impossible, that there's been a push to change that name in several countries. It's already been changed in Japan, South Korea, and Taiwan. And with that name change came reductions in stigma, clinicians more willing to disclose diagnoses, and individuals and families more willing to seek care. And in fact, with our Consumer Advisory Board, we recently published a paper that surveyed people across the United States about changing the name here. And the majority reported that the name is stigmatizing and should be changed. And this is not just amongst people who have the condition or family members, but across researchers, clinicians, policymakers, and then just members of the general public. So I think that really speaks to the importance of language, that words really do make a difference. Next slide. Okay, so I just want to briefly speak about prevalence here. So you can see on this slide, sorry, my screen just froze on me, that psychosis is a lot more common than most people think. You can see here that about 17% of people report having a psychotic-like experience. Of those, about 8% meet criteria for a risk syndrome, and about 3% of those will go on to develop a psychotic disorder. Next slide. Of the 3% of those with psychotic disorders, the worldwide rate of schizophrenia is generally thought to be around 1%, with some variation noted across studies and populations. The peak ages of onset for the disorder range from 15 to 30 years old, with 21 being the average age of onset. Early onset schizophrenia, as you can see in that graph, tends to occur more in males. And as age increases, males and females tend to have the same rate. The latest incidence rates available for Massachusetts indicate that around 2,000 people have been diagnosed with schizophrenia. So with that, I'm going to turn things over to Kelsey to speak more about early intervention.
Sure, thank you, Raquel. So I think that was a great overview of just what psychosis looks like and how many people really will be experiencing, if not, schizophrenia, which is that 1%, some sort of psychotic-like experience, maybe that has some level of distress, or they might come to you about for help and questions. So really my goal is to talk about what early intervention is and why it's something that we care so much about. So to start, I'll just show that we're really not intervening as early as we would like to as of right now. So currently the average adolescent is psychotic for about 18.7 months. So that's over a year and a half before they connect to treatment. So that delay between when they first start showing symptoms and when they first get into the door of any kind of treatment. The WHO, the World Health Organization, recommends that lag is less than 3 months. So we can really see that we're really far behind what we should be doing and what is recommended. And the reason that we care so much about this is that those first 1 to 2 years of an illness are a really critical period for young people. So you can see it's the time when a lot of physical changes happen in the brain. The greatest deterioration in things like functioning and cognition. So being able to, I'm sure this is very important for school, think clearly, have things like memory, active functioning in their day-to-day life. Those first 2 years are a really important period for that. They're also the time when a third of suicides are completed. So it's really a life-saving period of time where we want to get people into treatment, and we want to be paying attention to how people are doing. Another point that I've put on here in this slide is that 60% of psychotic disorders are diagnosed in emergency settings. So this is really when somebody gets to a moment of crisis. And we really think that we can be intervening before somebody gets to that moment of crisis. They generally will be showing those signs that Raquel was talking about long before they get to that point. And you in a school system might be the first person to see that. So that's why we're here talking to you guys today. That's why we're excited that so many of you guys have shown up to kind of listen to these experiences that we're talking about. And just to echo what Raquel was saying just now, that recovery is possible with timely help. So if we can get people into care soon, we can really make a difference in the trajectory of their illness and, hopefully their life. So this is just a graph really explaining that a little bit better, that with early intervention, our hope is that we can avoid this really serious dip or long-term issues, and promote people leading the lives that are healthy and that they want to live. And so our role, so Raquel and my role at MapNet, is really to support the treatment centers across Massachusetts. So I won't go into the details about the research and studies around that, but this slide is just to say that there is an evidence-based treatment that we have for early psychosis, specifically the first time that somebody presents with these types of symptoms. It involves a coordinated type of treatment between people like psychiatrists, so people who manage medication, people who are doing individual therapy, support with employment and education, support for the family. So a bunch of different providers on one team that are specialists in psychosis and can support somebody on their pathway to recovery. So if you get somebody connected to a program, this is generally the standard of care that they would receive in the state. We have a bunch of different programs. We'll show later MapNet's website, but we have a directory where you can see really which programs are closest to you in the state. Another really important point here, so we have a lot of research on this model of care showing that it works, but that research also shows that the people who got the most benefits out of that treatment were the ones who got into care earlier and faster. So again, those treatment delays are really critical. And it's really important that we, not just us in the treatment world, but people in the community are able to recognize psychosis early and help people get into treatment early. So here is a picture of our website. We have the link down here. Maybe if we have time at the end, we can go into it a little bit more. You can see our program directory up here. And we also have resources where people can read a little bit more about psychosis. And if you're a provider, you can get some of our MapNet resources that we offer to clinicians as well. I've also included a link here just to show that MHTTC has a lot of resources too around training and information on psychosis. So I'm happy to answer more questions about that or talk more later, but now I'm excited to turn this over to Dan to give us a little bit more of a firsthand perspective on what early psychosis can look like in a school setting.
Thank you very much, Kelsey, Raquel, and Dana. So I'd like to start actually with introducing myself. I'm Dan. I'm a certified peer specialist. I'm a writer and I'm also a member of the Consumer Advisory Board that Raquel mentioned, and really excited to be a part of that great partnership and all the great work that we're doing. And I also am a Let's Lead New England Fellow, and I just wanted to start things off with describing a bit about the project and that program. It was an opportunity to really develop a cohort of people throughout New England to strengthen our voices and roles in the recovery movement. And it provided so many opportunities and mentorship and funding for projects. And my project was, based on stories, which is a lifelong interest of mine. And it was kind of 3 parts, and one is ongoing, or 2, I guess. I was able to teach a writing true stories about mental health workshop with my mentor for students in Canada. I worked with my mentor, author Kathy Friedman, who has a book coming out in April. Very exciting. on my own personal writing. And I also began the Continuum project, which is a series of just qualitative interviews based on, I hesitate to even call them interviews because it's just providing the space for people to, think about the evolution of the sense of self and identity. And Kelsey, if you could just advance the slide. Thank you. And it's based on some research in a growing field of what's called narrative medicine. I think of it as just, growing from understanding others and ourselves. And Arthur Frank has published a memoir regarding, his own story of, experiencing physical illness. And this quote, I think, resonates and sums it up well, that the wounded storyteller ending silences, speaking truths, creating communities becomes the wounded healer. And yeah, so just one more slide, yes, thank you. And so the project I am continuing, continuing anyways, is based around the question of how have you continued, which is asked in regard to the state of the world right now with COVID and everything. But really just to provide a very open-ended question for any sort of response with the people who wanted to share their story, and then be revisited months later to reflect on the growth and the process of sharing your perspective at one moment and then revisiting one's perspective, after living life for a bit. And with that, I'm going to actually enter into my own lived experience presentation, because if you want to stop sharing now, Kelsey, that would be good. But I wanted to begin there not only to show, how much hope and growth there is, and opportunities within and the recovery movement, but also to show how much hope there is when experiences are found early on the spectrum, the continuum that Raquel discussed. And so my interest in storytelling has been a lifelong creative pursuit. I'll soon describe times when I encountered disruptions, at times related to creativity and language, but my experience with early intervention is that it promotes self-determination in setting and pursuing my own goals in my life and as part of my recovery. And so as my work as a peer specialist, and also from supporting and learning from my peers, I've also found that my experience in early intervention differs at times greatly from the other avenues of treatment, shall we say, that can occur, as Kelsey was talking about, after crises occur. And that all goes to say, I do think that early intervention is the way to go. And number two, my story has grown because of my lived experience and with the opportunities that I've been given and found, such as the finding the restorative element of storytelling based on telling my own experiences after different times in life, and times have passed. And my story begins in the affluent suburbs of Boston, where I had great support from my family and friends, and I, experienced all the, privilege and, just love in the world from them growing up. And I was very good at school. I excelled at writing and music. I remember in 5th grade, a teacher saying that a essay I wrote on Tuck Everlasting, which is a cute children's book about immortality, she said it was high school level. And that got me thinking at an early age, like, where will this go? So jumped to high school. I was finding classes harder, just everything moving, generally well. I was still a very good student, but I began sleeping less and less, and with the stress of college and harder subject matter, I, was noticing something in my own thoughts, sort of what I would call a fascination with the random, mostly in reference to writing and creativity, but that sort of existed in that blurry area between creativity and nonsense. That that all said, I did get accepted to my dream school and had the opportunity to take some time off before going to college, in which I traveled, to New Mexico, to England, to Italy, just having so many opportunities before me that did allow me to see the world, even as I was still noticing that I was experiencing something that I hadn't before. And I will add that this was all happening when I was like 18, 19 years old, at the transitional age when many mental illnesses can first become disruptions. So when I got to college, I did quite well my first semester, and I found that it was intense and that my classmates all around me seemed so confident and smart. But I found that I could keep up. And then I did notice that people seemed curious about my manner of speaking and thinking, but it was the only way that I had ever known. So I shrugged those comments off. But it did get me thinking, like, maybe there is something different about me. And then I had an experience after that first semester when I went to an immersive Spanish school over the summer and spoke Spanish for 2 months straight, knowing very little of it when I began. And then when I, re-entered speaking English, I found that speaking English, I felt more, more trouble finding words, and, felt more disorganized in my life as well. And I, was again intrigued by that, but also concerned. It's like, why was I thinking more like the way I know I can think when I was thinking in Spanish versus when I'm speaking English? And so the semester after that experience, I, was doing worse in classes than I had ever done. And I was spending a lot of time out of class, writing or just thinking, it's like, why is this so hard for me? And I would be writing things that I, enjoyed, such as poetry, considerations, and sorry for that fire truck. But an example of those things is, now styling like a lion, I'm resolved, self-reliant, like a hominid, yeah, I did. The evolved client, now among them, I'm a giant. Which is kind of good, especially if you want to be a rap mogul like I did, kind of. But the thing was, I had 7 essays to do. So not the time. Anyways, I did forget to mention that prior to that semester, I had been diagnosed with ADHD at the age of 19, which is not the time to be diagnosed with ADHD, and I was given a prescription for Adderall. And so along with Adderall and smoking weed, I found myself sort of in a bind of feeling like fuel was being added to the fire of the different styles of thinking that differed from what I was familiar with. And also at that rather intense college, there were times when other people, were experiencing disruptions, and there was a lot of, stigma and discrimination, which are the same thing. Referring to those people, it's like, oh, so-and-so went crazy. And that, got stuck in my thinking that might happen to me. And that prevented me from reaching out for help because I was scared. So I took some time off from college, found myself getting a job in New Mexico, just thinking I needed to get away, and I ended up at times needing to cook 3 meals a day for 30 people, which, as you might imagine, was a very stressful environment and was not conducive to just thinking about what was happening. So when I did get back at home, I felt more confused than ever. There was like a pervasive feeling at that time that similar to when you walk into a room and you are thinking that you're there to get something, but you forgot what you went in there to get. And I withdrew from college for medical reasons, and had no hope at that time, I suppose. And I didn't really want to see my friends or really talk with my family about what was going on. And I got misdiagnosed, or I got diagnosed with depression because it looked like depression at that time. And like I said before, I had previously heard about how I was looking like I might have ADHD, neither of which, resonated with me. And at the time I was meeting with a number of providers, and one of whom, was the first to, describe what I was going through as psychosis. And that was in our first meeting. And I was like, whoa, you just met me and you're calling me psychotic? This ain't gonna work. And I still meet with him to this day, by the way. So it did get me thinking. It was jarring, but it got me thinking. And I eventually asked another one of my providers to get in touch with the First Episode Clinic, which I had read about online. And he made some calls on my behalf, and which referred me to a clinic where I heard that I was at clinical high risk for developing psychosis, which is a term that I share for two reasons. I didn't know what it meant or that it existed, but it did sound right that I was like on the cusp of something, and I was seeking things right when they were disrupting what I really wanted to do in life. And I was comforted to know that there was a framework to address my concerns. It also does speak to the spectrum that Raquel was speaking of, because I was, being so close to Boston, being, so well accessed and so privileged to find the right providers at the right time. I was able to catch this pretty soon, which is, the work that is before us is how do we provide those opportunities and that access to everybody who might benefit. And so my experience in early intervention included some family therapy, some group therapy, a lot of catered just coaching to like what felt important to me. And I felt like my self-determination was fostered in that environment. And I feel like it was built not only on the individual seeking support at that time when they notice that their thinking is becoming something different, but also that it is based on a framework that felt comfortable to me, like all in, an outpatient setting. And it's actually quite welcoming compared to different post-crisis kind of formats that I've, been more exposed to in my professional work as a peer specialist as well. Not to say that the people who are, in recovery or have found those places as part of their recovery or at the beginning of it are, unlucky or, finding some other, degree of satisfaction with life. It's like all of our stories are equally important, and this is just so happens to be mine. So that is most of it. I do want to loop back on some of the early signs, and I'll end at that moment. But basically, back in high school, and given the topic of today, I did want to bring up, even though I was an extremely good student, had a, maybe not extremely, but a good enough to get where I wanted. I do think there were some early signs. The primary one being sleep deprivation. The only time that anybody in terms of like an educator role told me anything about like what I was doing might, be something I might regret down the line, was a history professor who, like, I was talking in class about like, yeah, I was up all night working on this, kind of bragging to my friends about it. And he was walking past and he had a degree in psychology as well. And he's just like, huh, that's really bad for you. And like, that was really the only sign early on that I was like doing something that might be a warning sign of, more disruptions or difficulties later on. And also senioritis is not a thing. It is a thing, but like watch out for that, because that's like entering that moment of huge stress of like, going to college and moving away from home and just all that stuff that can just for entirely life reasons just be stressful. Also, just opening the general discussion of mental health in schools, like not focusing in on like the crises sort of events, like the school-wide like assemblies for suicide prevention, which really does make the topic much more weighty than having a simple, or not a simple conversation, but a personal conversation. It's like, how can we support you? What is happening at home? Just why'd you stay up all night, Dan? So I think that's where I'm at. Thank you all for listening.
Thanks so much, Kelsey and Raquel and Dan, for such a wonderful presentation. And thanks so much, Dan, for sharing your experience. I think that Martha and I have a couple of questions to ask before we open it up to the audience. So first, I'm just wondering, what do I do as an educator if I recognize possible symptoms of psychosis in a student?
I can just start. Depending obviously on what the signs are, it can be anything from, if somebody is clearly in the middle of an episode where they're hallucinating or having very strong distressing delusions. Obviously at that point, you're going to want to try to connect someone to care. But if it is really in that earlier stage of this person seems to be struggling, we're not quite sure what's going on, I'd be interested, Dan, on if you have any other thoughts on this, but really what you were saying about stigma being what stopped you from reaching out to help, creating an open environment where they can talk to you about that, being that trusted person who brings that up and points that out to them, and asks if there's a way that you can support them. That's really the first thing that comes to mind for me. And then, of course, on MapNet's website, we have resources that people can read more about psychosis in our program directory, where you can find contact information for different programs in your area. But again, that's if it's more on the extreme level. But really would encourage people to be having more open conversations about mental health with students when they're not in a moment of crisis like that. But I'll pass it off to either Dan or Raquel if you have other thoughts.
Dan, do you want to comment first and then I can say a few words?
Yeah, sure. Thanks, Raquel and Kelsey. Kelsey, just to answer your question about like how the self-imposed discrimination might, for like these words that are scary and large, like the renaming paper discusses, is just, it's hard to ask for help when you don't know what you're asking for help for, if you know what I mean. Like, it's a lot of the times, and I think what really got in my way is I didn't know how to ask for help, and I didn't want to admit that's like, yo, something's going on. It's just like, this is the first time that my sort of creative, circuitous way of going about the world got in my way. And it was also something that like I did hold near and dear to who I was, all my life. And so it's like a tender moment of like, it's like, this is different, but also still me. So what am I, how am I even going to put this to words? So it can be really difficult to ask for help when you don't know what you're asking for help for, which is why awareness is really integral, and also just having an accepting culture and a comforting space. Like, that's why I brought up like just asking about what's going on at home, like how are you doing with your friends? Like if you're an educator and it's like just are noticing something different about a student, like, and it depends on your relationship with them, but just be frank and just be like I notice that this is different, and do you agree? Do you think we can talk about why?
Yeah, I mean, I was just going to very quickly add that I think, anything that we can do to reduce stigma and normalize mental health concerns is so important. Mental health is part of overall health. And I mean, I'll just say I have a child in high school, one in middle school, and maybe one of the things I've noticed that has happened throughout the course of this pandemic is that so many people seem more willing to talk about mental health concerns than they have in the past. I noticed both of my children, they and their friends seem so much more open about it than when I was growing up, when there was so much shame associated with having any kind of mental health concerns at all. I mean, if anyone was feeling anxious, depressed, having a hard time concentrating in class, no one talked about it. It seems a lot more open, at least from what I notice now. And I think with that comes just this willingness to disclose to school professionals and seek help from mental health providers. So the more we can create an environment like that and really emphasize this recovery-oriented language that we spoke about before, very strengths-based, hope-based, normalizing that treatment is available, recovery is possible, that really goes a long way. And as Kelsey also mentioned, we have a long list of resources on the MapNet website, not only just about psychosis and signs of risk, but different providers in the area. So if there's ever any question, you don't have to figure it out on your own. You can always contact one of the resources on the site that specialize in these kinds of difficulties, and then an evaluation can be done by one of the providers and figure out the best next steps from there.
Thank you so much for all of you for answering that question in such a multifaceted way. And there are so many great questions in the chat. I know Courtney and I had some questions that we were going to ask, but I really want to switch to the ones that our audience are asking because they're just such great questions. I wonder if while I'm doing that, if one of you might be able to put the web address of the resources that you just referenced, Raquel, and MapNet in the chat for folks, because I think that we're going to get a lot of questions about how to connect to resources and learn more. But one of the questions we got in a private chat is, as a parent of a child experiencing psychosis, how can I get care for my child when their psychiatric provider does not advocate treatment beyond monitoring? And I think this question really, there are those of you who specialize in early intervention and are knowledgeable about this, and then other providers who might not have the same breadth of expertise. So how do you manage these sort of just conflicting advice about what to do with a child who is experiencing psychosis. Any of you can start. It's a tricky question, so.
I would think so. In this situation, the provider either doesn't think it's psychosis or doesn't think that the person needs additional care. I mean, my first, instinct to that is to, get a second opinion or connect with somebody who has more specialized knowledge in that area. I mean, we really do try to work with people's current providers and make sure that they're on the same page, really be partners with them in getting people into treatment or supporting them through recovery. Raquel, since you've worked more directly in the treatment realm, I'm wondering what you think, but that's what comes to mind for me, is just to get a second opinion. And you can always call a program and just get consultation on what's happening with the young person like that. You don't have to do a full intake into a program just to get a professional opinion in most places.
I think that's great advice, Kelsey. And, I don't know if the person that you went to or your child went to was at a specialty clinic for early psychosis. But if not, I would definitely recommend trying to seek care from one of those kinds of specialty centers. And I'll say the vast majority of them offer telehealth at this point too, so that distance doesn't necessarily need to be a barrier, at least at this juncture.
Great. Thanks so much for your thoughtful response to that question. So it looks like our next question is coming from Denise, and she asks, Dan, if you could share if smoking pot came before symptoms or after symptoms, and maybe what impact that might have had. And maybe if Kelsey and Raquel can kind of chime in on the role of marijuana in psychosis.
I would say that it came, or the symptoms or like the experiences that I was noticing in my thinking were there before I smoked weed. And I did mention how, like, during some of the times of my life when I was, really trying to comprehend, what was happening already, like I was smoking more than I should have. And I do feel like that did, add fuel to the fire. But I do want to also add that, not to compare them, but, amphetamines and like things, ADHD treatments, like Adderall, which I had, I actually found to be more disruptive to my thinking, like long term. So I think that if we, acknowledge that marijuana is an element that can like disorganize, that can, further psychosis, I think, and it has been shown that amphetamines and stimulants can also, do the same, or maybe not the same thing, but they can, lead to similar disruptions. They're both things to watch for. So
Raquel or Kelsey, did you have anything to add about cannabis and early psychosis? I know this is a big question that comes up.
Yeah, I mean, I can just
teenagers.
back up kind of what Dan had said, that there is a lot of research being done right now on if there is a link between cannabis and psychosis. It does seem like that there is evidence for that, and that specifically with high THC products, or depending on the amount that somebody is smoking, if they are at risk, to start with, that can, I think, Dan, your wording is perfect, add fuel to the fire, so to speak. So that's something that I think is really worthwhile for people to be aware of.
Right. And if you're already at risk, it could be because of a family history. Then what we know is that smoking marijuana can definitely increase the likelihood of converting to a psychotic disorder. So definitely something to keep in mind.
Definitely. And for that at-risk population, and also just like examining, like, why is this person smoking marijuana? Like, is it, you know, just every once in a while, or is it like for something else? Is it for like exploring some way of thinking that might be unfamiliar?
We have so many good questions in the chat, and I know we're coming to the end of our time. Maybe our presenters might be able to answer some of the questions that we could send out after the webinar, because these are really great questions. Just quickly, I just wanted to note this question about the red tape in schools and school professionals in getting kids connected to first episode psychosis programs or early interventions. Do you have any thoughts about how to make that process easier within schools?
I would be curious if you can elaborate maybe a little bit more on the red tape. If there's things that you're not allowed to talk about or connections you're not allowed to make as a teacher. I'm not as aware of those, and of course it might be different system to system. But as far as just talking about experiences with students or working on things like taking away stigma, being more open about mental health. I would imagine that those are things that you can do, little things in day-to-day conversations. But yeah, I can imagine if, you as a teacher can't make a referral maybe directly to a program, but could bring something up maybe with parents or if there's a school psychologist. But again, I'm not totally sure what the red tape is, so to speak, in that situation.
Yeah, I'm also not aware of specific issues regarding red tape either, but if there are those kinds of issues, we would love to hear more about those, because we're in direct communication with the early psychosis programs in the state all the time. And I think it would be good for them to have feedback if there are kind of barriers to getting care that's needed.
Yeah, I will say part of MapNet's role is to understand or have a little bit more of a picture of the big overall system of how people get into treatment. So yeah, if there are barriers that we're not aware of or not working to address right now, that would be great for us to know and potentially see if there are solutions to.